You're taking handoff report for a patient scheduled for elective surgery this afternoon. Everything seems standard, but walking into the room, your patient is dealing with severe nausea, vomiting, and diarrhea. This is unusual considering they've been strictly NPO, receiving nothing by mouth for the last 12 hours. You feel the schedule ticking away. It's Ozempic. A newer nurse might just check the box, assuming it's a simple low-stakes diabetes or weight loss tool sitting quietly in the background. Gliding past this single prescription turns a seemingly routine surgical admission into an unrecognized escalating crisis. You pause to apply the clinical judgment measurement model, mapping the physiological data to find the root cause of the patient's distress. Ozempic is a GLP-1 receptor agonist. Its main job is to intentionally paralyze the gut to slow down digestion and make the patient feel full. Look at this cross-section of the stomach. That chemical barricade traps whatever is inside. The body tries to expel it, resulting in days of prolonged vomiting and diarrhea, which rapidly drains the patient's fluid reserves. Because of that severe fluid volume deficit, the patient becomes profoundly hypovolemic, and their overall blood pressure tanks. Kidneys require a massive, high-pressure flow of blood to filter waste. When severe dehydration starves the highly sensitive kidney tissues of oxygen, you get an acute kidney injury. The drug itself doesn't poison the kidneys, but the resulting dehydration damages them. Your immediate intervention shifts from suppressing nausea to starting aggressive IV fluid resuscitation to restore blood flow to those renal tissues. Identifying the root cause of that fluid loss and protecting the kidneys takes priority over simple nausea management. With the kidneys stabilized, you have to evaluate if this patient is actually safe to go into the operating room. Usually, a 12-hour fasting window guarantees an empty stomach, but the medication's core function completely invalidates that protocol. Here you can see how a complex, heavy meal eaten over 24 hours ago might still be sitting entirely intact inside a paralyzed digestive tract. When an anesthesiologist pushes deep sedation, the patient loses their gag reflex and all airway protection. That retained food can easily travel up the esophagus and into the lungs, causing a massive aspiration pneumonitis. You immediately flag the Ozempic on the chart and alert the surgical and anesthesia teams to halt the procedure before the patient goes under. Identifying delayed gastric emptying at the bedside provides the essential alert that allows anesthesia to adjust their plan before induction. The surgery is rescheduled, the patient is stabilized, and now you're preparing them for discharge. Clinical judgment extends past the hospital doors to prevent future emergencies at home. When a patient drinks alcohol, the liver becomes occupied metabolizing toxins and stops releasing stored glycogen. Because the drug already prompts the pancreas to release insulin, turning off the liver's backup sugar crashes the blood glucose into sudden, severe hypoglycemia. You also have to warn older adults about a silent, long-term threat caused by rapid weight loss: sarcopenia. As the drug intensely suppresses appetite, a starving body will start breaking down its own skeletal muscle for fuel. Preventing severe frailty and falls requires strict daily protein intake and resistance training. Finally, you must outline the rigid storage rules. The Formapen is opened, it has to stay in the refrigerator, strictly between 36 and 46 degrees Fahrenheit, but they can never freeze it. Ice irreversibly shatters the medication's fragile peptide protein structure. Even if it thaws and looks entirely clear, the drug is completely useless. By looking past the standard admission checklist and neutralizing these metabolic threats early, you ensure patient safety extends from the hospital bed to their daily lives at home.